Donna, good looking is whatever it means to you, mate.
I just
I'm a wee bit concerned about what kind of aspersions you're casting in the direction of Nick and John, who are already here, but nobody would deny their gorgeousness. So for you today, let's take a moment to anchor ourselves into this space and give ourselves permission to sink deeply into the ideas, your values and passion around providing the best quality rehabilitation you can. So enjoy the sound of this te reo as we go through this karakia together. Just do talk along with your mic on mute if you want to. Whakataka te hau ki te uru. Whakataka te hau, ti hau ti, ki te tonga. Kia mā kina kina ki uta. Kia mā taratara ki tai. I he ake ana te atakura. He tio I huka I hauhu. Tihe Moriora. So it's my very great privilege to welcome together John Bagnell, Nick Kays, and William Levack for us today.
get them for the transitional care. They often go on.
You just remember to keep yourself on mute. So we first up we have John sharing for 5 minutes, then Nick, then William sharing their thoughts on what is quality care in rehabilitation. Then we're opening it up to then I'll be leading posing some questions to each of the speakers and opening up the floor then to you to pose your questions or comments to the speakers. So do make a note of anything that comes to your mind as we go through the presentation, and we'll have that opportunity to take that to the floor later on. We'll finish up by 10 to the hour. And so just to introduce our very special guests today, John Bagnell is a physiotherapist with international expertise over the past 20 years. Kia ora, John. He's worked in a wide range of settings and is currently an advanced clinical clinician at Counties Manukau and allied health consultant for stroke neurology and rehab at Te Toka Tumai, Auckland City Hospital. He's also president of ANZSO Aotearoa and a member of the National Stroke Network. John's a keen advocate for person-centred and whānau-centred holistic approaches to rehabilitation. He's an international bow bath instructor, teaching and mentoring physio and OT in New Zealand and abroad. And following John, we have the fabulous Professor Nick Kays, Professor of Rehabilitation and Co-Director at AUT in the Centre of Person-Centred Research. She has a background in health psychology, and her specific expertise draws from the intersection between health psychology, disability, and rehabilitation, exploring what we know about how people think, feel, behave, and respond in the context of injury and illness. So special welcome, Nick. We're really grateful to have you here. And finally, our third speaker is Professor William Levack, a physiotherapist and Dean and Head of Campus at the University of Otago, Wellington. William's founding member of the Cochrane Rehabilitation Group, established in 2016, and a past president of New Zealand Rehab Association. William's published extensively on rehabilitation, including co-editing a book, A Rehabilitation Goal Setting, Theory, Practice, Evidence. William is passionate about research and rehabilitation for people with neurological and chronic respiratory conditions, as well as broader interprofessional person-centered and engagement-related issues in rehabilitation. So with that beefy bio from our fabulous speakers, I'll now hand over to John. John, the clock starts now. What is quality care in rehabilitation and how do we achieve it?
Thanks, Fee. Yeah, and it's a big question, eh? But yeah, thanks for having me here to talk about it. I think the first thing that comes to mind for me when we think about quality rehab is about something that's based around the person. So it's based around the person and their whānau, what they they should really be at the center of everything. It's really about what they feel are their priorities, what the kind of things that they value getting back to. What did their life look like before whatever incident it is that's brought them into rehab? And really, we're here to kind of help them figure out what life looks like next. For quality rehab, we really need processes that support and encourage whānau so that trust and connections can be built, so that whānau and rehab teams can be, in the waka together, going forward together, working collaboratively as one big team. I really believe that quality rehab is about trying to help the person fulfill their potential for recovery. I'm very much in favor of a restorative approach. Based around what we know about neurophysiology, how the brain and the body is affected by injury, how it responds to therapy. We have all this wonderful research around neuroplasticity that tells us that the central nervous system can respond to things and can start to find new pathways. There are ways that different factors that we can try to control to help guide how that recovery happens. Things like repetition with variation, things like picking salient, meaningful tasks for patients are quite important. And I think that's really good for us to use that knowledge really to steer what rehab looks like. I'm very much in favor of rehab starting with looking at tasks that are meaningful for the person, looking at them within their occupational performance, really using clinical reasoning tools to help clinicians guide their therapy, things like the ICF, where you got to look at body structure and function, activity limitations, participation. They really help clinicians kind of guide the clinical reasoning process and allow them to kind of zoom in and zoom out as they need to. Quality rehab really needs an IDT approach. So we have all these wonderful different disciplines, especially in this country, from OT, physio, SLT, dietetics, social work, that can all come to the party with slightly different perspectives. And it really needs to be a 24/7 thing. So it's no good the therapist going away into the gym and doing something whizzy with a person, but then actually for the rest of their day they do something completely different. It really needs to be 24/7 and consistent approach. And we need to try and look at the person as a whole person, not just a hemiplegic arm or an injured leg. I really like to take the approach of the patient, thinking about the patient's learning. So we really need to, in rehab, to create an environment and experiences that enable the person to learn. That might be implicit or explicit, not necessarily verbal instructions, but really working with the whānau and the patient to give them experiences to kind of go through a process of learning to move again. I always think about with people who've had a stroke, that's a good example. They wake up with this body that's completely different. They start trying to move around with it and trying to get back to doing things they enjoy. And our job is very much around to kind of guide that learning. We don't have the answers, as a therapist. For me, when I might see a patient and the patient's in front of me and they might have a right MCA stroke, and I might have seen hundreds or thousands of people with the same stroke before, but I've never seen that person before. I don't know how to fix them. I don't know what the answers are. I can just kind of work with them and help guide their learning to try and figure out what works for them, what kind of potential they have for recovery, and how we're going to go forward together. I always think from a learning point of view, then the aspect of challenge comes in, and there's some really nice research out of AUT recently around challenge and how it's important that we get that level of challenge right for people, so that it can really enable that learning. And again, that kind of consistency of approach across the whole day for the person and their whānau across the IDT. My 11-year-old came home with some maths homework a few weeks ago, and that really made me think about, I have no idea how to do long division. I had to YouTube it to try and figure out how to help him solve the problem, and he went back to his maths teacher and they went, "Oh, that's not how we do it here." And it's conflicting information of how you go about solving a problem, and it's not really useful for learning. So we need to think about as a team, from the nurses to the therapists, that we all have a very consistent approach to what we want to do. And I think that's my time.
Lovely. Thanks, John. Fantastic. Lots to unpack there. Nick, what is quality care and rehabilitation, and how do we achieve it?
Kia ora koutou. I agree with John. I think this is a super big question, and I think I'm likely to only be inherently partial in my response as a consequence, but actually I can already see some great threads of commonality as well. I think probably perhaps predictably, I conceptualize quality rehab as people-centered rehab. That makes sense given that I'm co-director of a research centre that has person-centered in the name. But I guess that begs the question of what constitutes people-centered rehab then. And I see people-centered rehab as pretty nuanced, complex, dynamic. It's value and context bound, it's culturally located, structurally dependent. So that in itself is a massive question. And I could talk about that probably for at least a day and not 5 minutes. So I think for the purpose of today, I'm going to focus on what I think are kind of two fundamental features of people-centered rehab. The first is meeting people in whānau where they're at. People in whānau often, in the context of injury, illness, and disability, are in a state of flux. So John just talked about people waking up with a completely new body as an example of that. People are often managing the emotional and cognitive work associated with that changed body and self. They're learning to navigate new, often unfamiliar spaces, the clinical environment being one of those. And sometimes they're learning how to navigate familiar spaces in different ways in the context of those changes as well. And for many people, rehab is an enduring process that long surpasses the time that they're in formal rehab services and service provision. This is what I often talk about as the psychosocial context in which rehab is delivered. And if we think about that as the context in which rehab is delivered, then achieving the aspirations of rehab in that context requires particular ways of working, such as being attuned to where people in whānau are at, both emotionally and physically, taking the time to really get to know and understand what matters to them and what's important to them. Sensing, noticing, responding, adapting to their changing needs and preferences across the rehab continuum of care, contextualizing rehab in the context of past, present, and future possibility, working in ways that support rather than compete with the biographical work that they are doing alongside that rehab process as well. And so these are kind of all examples, but probably not an exhaustive list of meeting people in whānau where they're at. The second thing that I want to highlight as a key feature of people-centered rehab and quality rehab, therefore, is prioritising culturally safe and equity-oriented rehab. Ideally, we would have equity in access, experience, and outcome for people who are accessing our rehab services, but the evidence highlights that we're not there yet. So if we look broadly at the evidence base for outcomes in the health sector, we know, for example, that Māori experience poorer access to services, and when they do access services, they experience poorer quality care and worse outcomes. So these are things that we need to contend with. These outcomes are also evident in our rehab processes. What else can I say about that? I think there's a great review that was published a few years ago by Sutonia Palmer and others who looked at determinants of health and Māori consumer experiences as a determinant of health. And one of the key things they highlight is culturally unsafe care as an intermediary determinant of health. Alana Curtis also talks about this in relation to the concept of cultural safety and cultural competency, and really articulates cultural safety as deeply connected to health equity. And so I think these are the kinds of things we need to be contending with if we want to really develop quality rehab and deliver quality care. We need to be delivering safe, culturally safe and equity-oriented care. I think that's probably my 5 minutes up, so I'll come back to more about that if people want to know more about that in a bit.
Right. Impressive timekeeping, John and Nick. Absolutely down to the wire and absolutely packed to the gunnels. Do we have a William Levack in the house? Do we have a William Levack? please stand up.
Hi.
Step up to the mic.
Hi, can you hear me?
Excellent. Yep, can hear you.
Can I throw up a screen shot?
Yeah, for sure.
Cool. Is that turning up? Share screen. Oh, share. There you go. Cool. I've got one slide. A one-slide slideshow. So I just wanted to add a different flavor to the discussion because John and Nick have covered so much ground already, and I wanted to just delve in a little bit into the historical concept of the idea of holistic rehabilitation a little bit. So partly this was sort of emerged because I've been reading not rehabilitation books, but books by this Greek economist called Yanis Varoufakis, who's been writing about, he has a particular style of writing where he writes his books as if they're framed as letters to people. So his latest book called Techno-Feudalism was a series of letters to his dad, who's dead, but he was explaining where global capitalism has got to, how we got here, what's gone wrong with capitalism, and how perhaps to fix it. And this got me thinking, if I was to write a book kind of like this about rehabilitation, contemporary rehabilitation, who would I want to address the book to? And these two guys here, Kurt Goldstein and Howard Rusk, were the two people that sprung to mind initially because they were there at the early days of rehabilitation when it was first being created during World War I and World War II. And they were pioneers in rehabilitation. And recently I published this paper about the development of a new scale for measuring problems with self-identity after traumatic brain injury called the Brain Injury Sense of Self scale. And the paper starts with the quote I've got there by Kurt Goldstein, which is to say that it's impossible to consider any illness, but above all a neurological illness, without reference to the patient's self. And likewise, Howard Rusk, who's sort of known actually in America as the godfather of physiatry or rehabilitation medicine in America, he wrote a series of books, but throughout his books is this concept of the whole person and needing rehabilitation, not just parts of them that have been damaged. And John and Nick have talked to this point throughout both their presentations. The thing I'm sort of pointing out is that these guys were talking about these concepts in 1920. So, you know, what would they be interested in about rehabilitation practice in the current day? And I guess the thing is that probably in the current day, they would be interested in they'll be fascinated by the technological advancements, you know, the new assistive technologies that have emerged, motorized wheelchairs, augmented communication, and all the new medications and surgeries that are kind of options that didn't exist in the 1990s. But there are other aspects of current practice that they might be surprised to find have been slow to develop from their day. And one of these, I think, is holistic practice, because what they were saying then is sometimes stuff that we have a lot of difficulty still applying to practice in our current practice today. And I think probably one of the reasons why this tension still exists is because there's a bit of a conflict between the principles of holistic care and the contemporary market-based approach to healthcare in Aotearoa and globally that's emerged from the neoliberal reforms in the 1980s. If you were working around that period of time, you might remember them. But these reforms sort of fragmented healthcare services from holistic social service into like a business, effectively, in the pursuit of like cost efficacy, transparency, and accountability. And so that we end up with a bit of a battle to provide services. There's a bit of a battle to justify spending time with people, finding out about what's important to them and helping them fulfill their own preferences within this context of this quite heavily sort of neoliberalized health sector. Evidence-based medicine has been a wonderful addition to rehabilitation, but also in some ways it's created problems with holistic rehabilitation because it emphasizes physical rehabilitation and stuff we can measure over the harder things to measure, such as stuff to do with social health and spiritual health, for example. And probably just to swing back to the concept of Māori perspectives on healthcare, it is actually Māori health perspectives on healthcare actually are add a arrow to our quiver to combat some of these sort of market-based approaches to healthcare and through the Treaty of Waitangi, because these models are inherently holistic, and the treaty gives us a mandate to champion these aspects of healthcare that otherwise would be sometimes a bit difficult to sort of justify. So I'm going to stop there, but there's a whole lot of discussion that could be had about strategies that can be used to how we can uplift and value holistic practice within these very increasingly market-based approaches to delivery of healthcare in Aotearoa. Thanks.
Thanks, William. Well done too on your timekeeping. So too, that does actually lead us very nicely into the first question I'd like to pose to our three panelists. And if we just have the spotlight on all three panelists, actually would be really good. So my question to you, and I'm going to start with you, John, actually. It's got a number of components to it, so do feel free to speak to any part of that comes to you. Bringing back to William's ending point around specific actions that we can take in this neoliberal evidence-based medicine shaped context that we work in, and in light of all of your arguments around what quality rehabilitation looks like, what knowledge, actions, or attitudes would enhance the provision of quality rehabilitation? Knowledge, action, attitudes. And I invite you to think about the personal level as well as the systems level. Personal stakeholder level as well as the systems level. Or in any one aspect of that, if you want to dive deeper into one component.
Yeah, I think what William, what you were saying there about the cultural aspect of it and what an opportunity that is, certainly at a service level for us on our kind of integrated stroke and rehab unit here, we've really used the mandate that we've been given around creating culturally safe spaces for people to and whānau to come into as an opportunity to bring Māori health models like Te Whare Tapawhā into our goal setting processes, and to really try and enable our clinicians to have time and some skills and experience to whanaungatanga with patients and whānau, and to kind of look at the person and whānau as a whole, and actually not just go in for your tinana, and actually look at Hinengaro and Wairua and whānau, and consider different aspects, and trying to kind of pull us away from just seeing the person as a diagnosis and going in to treat what's wrong with them all the time. And I think that's the Te Ao Māori is a real opportunity for us to kind of see the person as a whole, and whilst trying to build kind of culturally meaningful processes for people, it also just pulls us out into something that's good for everybody, and just trying to see people as a whole. I was thinking about kind of attitudes and knowledge and different levels around this question, and I think certainly from a ward point of view, having the attitudes of the team delivering the rehab is key here. They have to be open. They have to be willing to push themselves a little bit and come out of their comfort zone when it comes to learning about Te Ao Māori and differently learning culturally safe practices, learning from each other, being flexible, having a real can-do attitude. And then I think from a more of a service point of view, I suppose just expanding on that and making the rehab experience as efficient and as good as possible for the person and their whānau. Setting up teams to enable them to be able to work with patients and whānau around what they want to do, and thinking about things like the pathways that patients move through, things that are key areas of stress, like transitions between wards, transitions between services, key areas that patients and whānau find really stressful, trying to make sure that they're smooth, that there's good communication. You have things like in-reach services and things that really make keeping the patient and whānau at the centre of it, keeping communication with them, keeping them involved and informed and as much as possible. Is quite important. They're just a couple of things really that sprang to my mind.
Thanks, John. A lot of things I would say, and thanks for bringing our attention to those moments of transition and that pathway of care from a person-centered journey through rehabilitation services. I invite everyone here today to pop your own reflections into the chat. We're giving the microphone to John, Nick and William, but also want to give you the opportunity to share what's coming up from whatever your position is in rehabilitation. So pop comments in the chat as they come along, but I just wanted to pass the speaking staff on to Nick at this point. Do you have a response to John's comments or something there that you would like to build on or put on the table anew?
Yeah, I mean, I guess I'm thinking about the system and organisational level role with some of this. I think, you know, Elena Curtis, who wrote about the distinction between cultural safety and cultural competency made a really strong argument for the fact that when we orient to a competency-based understanding, we focus on the individual practitioner and all the responsibility resides with them. Maybe that's one part of the puzzle, but actually I think she argues really nicely for organisational level accountability to create the structures and environment to enable the delivery of culturally safe care. And so I think really stepping back and thinking about the organisational accountability to create that environment is pretty important. I often talk about people-centered cultures of care, and one of the reasons for that is so often our structures and processes compete with the aspiration of people-centered rehab. You know, the focus on expediency, workflow, efficiency, discharge, key performance indicators, you know, which are about length of stay and getting people home quickly, and all of these kinds of things can sometimes overshadow our ability to focus on what matters to the patient and to view them in the context of their broader rehab journey. You know, our episodes of care are focused on what's within scope here in this moment within the 6 weeks or however long we happen to have with this person, rather than thinking how what we do now might set up or make a difference for someone in their longer term when they're going to be grappling with this journey for a lot longer than us. I think another thing when I think about person-centered cultures of care as an example is what we do to support our rehab professionals. They also are persons in this process and often are in a system which constrains their ability to deliver the kind of care that they would like to deliver. There's a really great framework that I'm a bit of a fan of called the Senses Framework in the United Kingdom that argues for these 6 senses, you know, sense of security, sense of belonging, X, Y, Z, and argues that both the person, their whānau, and the healthcare provider needs to experience all of those 6 senses in order for good quality care to be delivered. And so how we enable our healthcare providers to also experience those things, sense of purpose, meaning, contribution, all of these things can help create the kind of system that we might want to create. Have I got time to add one more point?
Might pass on to William at this point,
Okay.
Kath, so Nick, so that we can actually
Oh, good. Perfect.
digest some of what you've thrown out there, and some thoughts are starting to percolate in the group too. William, I'm just going to say your response.
Okay, so I was just reflecting on what the question you asked John about, like at a personal level or a systems level. I think at a personal level for individual clinicians, good quality rehabilitation and holistic rehabilitation and person-centered rehabilitation kind of occurs despite the system, and people you know, spending a bit of extra time in their lunch to spend a bit longer with an individual person to get to know them a bit more, or thinking a bit creatively in ways that they have to sort of work outside the box a little bit to connect someone with a community organization that's a little bit beyond the sorts of stuff they might be doing in a gym with them, for example. So I think a lot of people online will be doing that as part of their daily business, trying to figure out how to make things. But I think the other thing that we can usefully do is figure out ways we can tweak the system to try and support this work a bit better. And there are a couple of things that we could advocate for. One of which is to have holistic measures of outcome that we're using as our metrics for evaluating the quality of healthcare. So when we're talking to health funders or management structures about what the key performance indicators should be for our health services, that we embed more broader evaluations of healthcare. I think there's huge value in advocating for patient and family involvement in the design and delivery of healthcare services, because that brings that perspective in. We've talked a lot about the uplifting of Indigenous ways of approaching healthcare. That's useful. And I think also supporting the continuing expansion of interprofessional education. But we can also reframe things, I think, from holistic care or person-centered care to values-based care. I think that's terminology that people outside rehabilitation can sometimes connect with a bit more as well. It kind of means the same thing, really, but it gives us a mandate to embed cultural and community values into and sort of whole of life impact of rehabilitation into our processes. Or the other thing probably just to say is that I'm aware that there's always a strive about what the funder's paying for, and they've got you've got this idea that somehow the funder's paying for 30 minutes of an assessment of a wheelchair and 40 minutes of a physiotherapy gym time. We need to make sure that our funding structures acknowledge the importance of clinical planning and goal setting and all those other elements of rehabilitation. Those are active parts of rehabilitation. They're not back office activities that are happening as well. So we need to build those into our funding structures, and that's the job of the managers to sort of advocate for.
Yeah, thanks, William and team. I'm opening up to the floor now for any questions you would like to pose for discussion. Do make sure it's a question rather than a comment. I'm sitting with first of all an acknowledgement of the challenge of the context that we're in and that many of us are working in, and also a lot of compassion for the intentions and sometimes the values clash for clinicians between the environment and what they really intend to offer to people and why they're there. So thank you all for doing that. But also some challenges out there, and we do have people here that be working at lots of levels of the system. Some really practical suggestions. Kat, to you, your question.
Kia ora koutou. That was really interesting from all three of you. I know John and Nicola. I work as clinical lead for rehab at Te Tatu Hauora, the Health Quality and Safety Commission, and we do a lot of work looking at quality improvement initiatives to improve rehab service access and outcome. And I just wondered if you had any tips for me regarding the current mandate not to have race-based projects and processes, when particularly in the major trauma space, we've got really good evidence that really shows that there is a big inequity for Māori in the way that they have a higher rates of injury, but also they have poor access to services and worse long-term outcomes. So I'm just looking for any advice or guidance from the three of you around how to not have a race-based program when actually the data is telling us that culturally led responsive care is what's going to improve outcomes for all New Zealanders.
It's not really race-based, is it? It's culturally based services that we provide. So, I mean, that's the first thing. We don't have race-based services. We've got culturally driven services. I think also standing your ground is really important as well. There is a big push against experts and expert knowledge in a whole range of disciplines, not only healthcare, and we need to be asserting a place in terms of being the best people to be making decisions about how to develop and drive healthcare systems. So stand your ground. Kia kaha, kia maya.
Thanks, William. Nick, were you wanted to step in there?
Look, I just I felt like you answered the question, Kat, in your reframing from race-based to, the fact that culturally safe, responsive services can benefit all. And so maybe that's the framing, right? Actually, that what we're trying to deliver is culturally safe and responsive rehab that can benefit anyone who accesses rehab, rather than it being race-based at all, per se. But totally agree with William. Stand your ground, totally. It's one of the reasons why it felt really important to talk about culturally safe and equity-oriented rehab as a critical component of quality care, because that is under threat at the moment.
Thank you.
And for those of you listening in, pop in the chat what would you say to Kat in the circumstance she finds herself in, to her question, even if it's encouragement. Shanthi.
Thank you very much. I'm actually following up on what Kat's just referred to already, because I'm also working in a relatively similar space. We are asked to, in fact, avoid words like equity and the Tiriti and Māori and Pacific focused indicators and outcomes, where it's really important that we don't get captured by the tyranny of averages, where things might improve for a group as a whole, but not for those particular underserved populations. So my question is very similar to Kat, but asking, do you have other language? You kind of implied already, William, culturally based, etc. will be language, but do you believe that there are ways in which we can frame this in a way that is palatable to the current administration?
I don't know if are you about to come in, William, or are you happy if I just...
I have trouble not talking, so I'm going to keep my mouth shut. You have a go.
Go, Josh.
I was just going to say, I think it occurred to me, if you take a step back and think about quality improvement and quality improvement methodology and frameworks, using data, if you can get it, to identify, you can't implement quality improvement projects across the board in your service in general. What you want to do is really target your resources at a specific group of people where you may be able to see that there's going to be a quick win, or you're going to be able to show some kind of difference in that population. So maybe just kind of sticking with that approach. And if you've got some data, like Kat says, she's actually got data around showing that actually there is this population of people where there is an issue, and to just actually target that group of people in a certain way, to actually target your resources at that person and go through quality improvement projects to try and improve outcomes for them is not necessarily about even equity, or it doesn't matter who that group of people is so much. It's just good methodology. It's good quality improvement methodology. So to kind of move away from saying it's an equity thing. I mean, I completely agree with William. I think we have to try and stand our ground as much as we can. But that is, when you think about language and approaches and how you might get things over the line, that would be my thoughts as a way to kind of say, look, this is just good practice. And it's not about the fact that actually it turns out that this group of people are Maori or another ethnicity. It's actually this group of people, we can see an issue and we can probably try and address it. So let's do it.
Thanks, John, and thanks, Shanthi, for raising such a just such a really real dilemma that you're in.
The other terminology is engaging. So instead of saying we're tailoring our service, you could say we are wanting to make our services as engaging as possible for all the people coming in. And so we want services that are engaging for everybody. And so we're going to develop an environment that is engaging for everybody. And so that does mean we've got this over here for these people, and we've got this over here for these people. So that might be another way of talking about it. Can I make one more point? Sorry. So the other person I really love hearing from is Trish Greenhalgh, who's a professor of primary healthcare from the UK. And if you Google Trish Greenhalgh, there's a number of presentations from her about politics, post-truth science, and evidence. And I once saw her talk about do a presentation on evidence in a post-truth world. And she talks a lot about how we need to learn as intellectuals and academics how to present a good argument, and it's more than just having the right facts. We need to connect with people emotionally and culturally, like the people who disagree with us. We need to connect with them emotionally and culturally, and we've got to be credible speakers ourselves as well. So she's written some really interesting stuff on that side of this work.
Thanks, William. Nick, anything you wanted to add before I move to Nikki?
No, all good. Let's move to Nikki. I think it's a super. I just want to acknowledge the challenge, the challenging context though that is being communicated in these questions. Yeah.
Nikki. You right, Nikki? You got your hand up? You might be pop it in the chat, Nikki. I'm not sure if your mic's working. No, it's hard to test your systems in a situation like this, isn't it? There was a question raised earlier while Nikki is putting that question into the chat around any suggestions for how we could address this tension between spending time with the person to get to know them and meeting them within the context of our systems. How do we meet those agendas for quality rehabilitation within the time constraints of our services? Nick.
Will I have a bash at responding to that? I think it's really complex, and I've just had a Doctor of Health Science student complete whose whole doctoral work really just highlighted the range of tensions that people experience in trying to deliver. In her context, she was focusing on the delivery of a relationship-centered approach that incorporated Te Ao Māori models of health, and she highlighted a whole range of tensions, that made it tricky. And so a lot of her recommendations are for actually how we really challenge and shift some of the structures that we're working with in order to enable these ways of working. So I guess just highlighting as a first step the importance of, really critically looking at some of the structures that we're working within, and some of them might be out of our control, but some of them are within our control. What we prioritize when we're writing clinical notes, how we manage and navigate an assessment, how we structure our discharge process. There are many things that are more within our control than we realize. I think the other thing that I would say is challenging some fundamental assumptions about time. Often people say that the reason it's not possible to do these things is because we don't have time. But there's a couple of things that I want to say about that. One is that we can embed a relational and person-centered way of working into everything we do if we prioritize that as the orientation via which we want to connect with people in whānau. So it doesn't necessarily need to take more time, but it can be a really clear orientation to your practice and way of working. The second thing I would say is that if we kind of think about the outcomes that we want to achieve, I got some people in a workshop a few years ago to kind of start with a clock and say, when this is the outcome that you're prioritizing, what does that mean for how you spend your time? And they came up with things like assessment, treatment, whatever else, all of course completely plausible and reasonable things that you should be spending your time on. But when I said, well, what about if the outcome that you are looking for is to achieve, health and well-being for this person in the long term, what then would you focus your energy on? And it completely changed what people said they would prioritize and spend their time on. So how we prioritize our time can sometimes be determined by the outcomes that we foreground to be important. So challenging some of those fundamental assumptions that we come to rehab with is a good starting point.
Oh, well, some real food for thought there, Nick. And recognizing the press from the environment, the context that we're working in, to take that lens around time, but raising that sense of awareness of, well, what personal choice am I going to make in this moment as my priority? John.
Yeah, I was just thinking, I know certainly myself and my leadership team and in our unit, we spend a lot of time trying to figure out how we reconcile the fact that our clinicians are just often under immense pressure to get people through the service onto the next thing. You know, when's the discharge date? Have you done this? Have you done that? Could you do it quicker? And we try and reconcile that with the fact that, you know, we want them to be able to spend time with patients, but also, you know, have the headspace to be focusing on well-being and what's important to them. And it's really tricky. It's really hard, and I don't think we're anywhere near having the answer to it, unfortunately. But it's constant conversations for us. Definitely, it's very hard for the teams that are kind of caught in the middle, really.
That's really helpful, John. And I think everyone's feeling very heard by the discussions today. And that in itself is really important. You know, and really great to have. I'm just loving hearing that contrast between, you know, Nick's philosophical stance and researcher stance, observer stance, and your, John, you're very practical. You know, we're facing this as a team. We're having these conversations and looking at what we're doing. So as a final question today, I want to highlight something that Janine, sorry, has put into the chat, my bad, Janine Van Blurk, around a comment you made earlier, William, about post-truth science, evidence.
Yeah, really happy to expand on that. I just saw that as well. To clarify, Trish Greenhow was writing about how do we persuade people about evidence-based healthcare in the context of an increasingly post-truth world, where the post-truth world sort of thing is where people don't even agree necessarily on what are the facts about a whole range of issues. And then when we're having discussions about what the right approach is to deal with issues, we can't get beyond the starting block, which is that we need to have the same sort of like understanding of what the sort of facts are. And so that was that reference to post-truth. And it wasn't an argument that science shouldn't be pursuing truth or anything. Just to swing back to Trish Greenhow's arguments, she was also sort of saying what we're really trying to do is persuade people. And people, going back to Aristotle, have talked about the right ways of the strategies you can use to persuade people. And as scientists and people who come from like a science background, a STEM background, we have a tendency to privilege logic and data and reason above all other methods of persuading people. And Trish Greenhow was just pointing out that that's only one of the things that we use. And if we rely solely on that, we fail to convince people who don't value that as an important part of. So it's about being aware of the fact that there's a whole lot of people in our world, including politicians and funders of healthcare, that don't necessarily have the same understanding of the things that are important to guide decision making as we do. And we need to understand where they're coming from so that we can communicate with them in a way that makes sense. And that's a whole nother hour presentation. So I'll just leave it at that for now.
Well done. And just want to pass the mantle back to John and Nick for any closing comments you have to the attendees today. Thank you, Jean and others, for putting the resources into the chat too as we speak.
I'm not sure I have a closing comment per se, because that might mean I need to be super wise to finish. But maybe I was just reflecting on the question around evidence and facts and William's contribution just there, and just acknowledging that the evidence we have available to us is inherently partial and you know, has a long legacy of prioritizing particular forms of knowledge and prioritizing particular forms of knowledge. And so I'm always all for, you know, as many sources of knowledge to contribute to the debate and the thinking, and to provide those persuasive arguments as we can, because the voice of our people in whānau often is the thing that gets minimised if we're only focusing on evidence and facts. And so, yeah, just acknowledging that complexity when we're talking about bringing different knowledge systems together.
John?
Yeah, I agree. I think probably what's important, I think, is just that we keep having these conversations, because to kind of verbalize it and validate the difficult situation people are in at all different levels of trying to provide quality rehab. I think one positive that I think of a lot in the 20 odd years, whatever I've been practicing, for everything is the way it is in the world at the moment, the fact that we have these discussions and the fact that like Nikki can talk there about the fact that, you know, a lot of that evidence is the type of evidence it is, and it's only part of the story, and the fact that that's recognized now and that it's talked about, and that actually, you know, we have very clever people who research that and can talk about it, and that's part of our discussions is a big positive, I think, because certainly 20, 30 years ago, I certainly don't think when I was trained as a physio, things were really talked about in that way, and certainly coming up through the healthcare systems, that wasn't overtly discussed, and it was very much just a medical model, and this is what you do, and all we're trying to do is get better evidence-based practice on the table. So I think a big positive for where we are now is that stuff that you were just talking about, Nikki. So that's, I think, a good thing to go forward with. Yeah.
Thank you, John. Thank you, John, for acknowledging to the power of this group and the conversation. So if you're looking for strengthen these in challenging times, then this is a really good place to be. And also for looping us back into the concept of the conversation. So if you're not already on our mailing list, do make sure you get on. We run these regularly throughout the year. And next up we have Megan Seguin talking with us about autonomy supportive communication and rehabilitation. I just also want to flag to you the AGM, which will be held July 22nd as part of the Ramsans Rehabilitation conference that's on in New Zealand, NZRA conference on in Christchurch this year. So that is some links to that will be in the chat, but you will also find it online July 20th to 23rd in Christchurch.
Can I add one more thing? I'm so sorry. There's the thing I feel I need to say, which is that you guys know you're awesome, and despite this whole thing, you guys are doing an amazing job in rehabilitation in New Zealand, and joining in and listening to these conversations is part of that amazing job. And you know you're doing a great job because patients in whānau will be telling you that. So keep it up, keep going, keep on keeping on.
Yep, tautuko too from everyone here on the leadership team at the NZRA. So just to close, I know you have more fabulous work to go on to do for the afternoon. So ka whakaira, whakaraia te tapu, kia wātia ai te ara, kia turuki whakataha ai, kia turuki whakataha ai, humie hui, taiki ai. Go forward, be strong. Ka kite anō.